Hello, and welcome to our live webcast, Pediatric, Osteomyelitis, Septic Arthritis, and MSK Infections, oh my. Thank you for joining us. My name is Caitlin, and I will be the operator for today's presentation. Before we get started, I would like to take a moment to acquaint you with a few features of our web event technology. On the right-hand side of your screen, you will see our text chat window. There's a large window which holds your sent messages, and a smaller window at the top where you'll be able to type in your questions. Send a question, hit in the text box, and type your text. When you're finished, hit the send button. All the questions that you submit are only seen by today's presenter. Your questions will be responded to in the order in which they were received, and they will be addressed at the end of our presentation. At the conclusion of today's program, we ask that you please complete a brief post-event evaluation. Please do take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Sarah Stelma, board-eligible pediatric orthopedic surgeon with a subspecialty interest in scoliosis, trauma, fractures, and adolescent sport injuries. She is a new partner to the Pediatric Orthopedic Center, and at this time, I'd like to turn the microphone over to our speaker, Dr. Stelma, for her opening remarks.
Great. Thank you, everyone. It's very nice to meet you all virtually. Let's get into this. So I'm going to go over mostly pediatric osteomyelitis and septic arthritis and what you need to know. And I threw in at the end a few other musculoskeletal infections that are very important to know about. So we're going to go over the etiology and pathogenesis, the natural history, some of the sequelae and complications, some of the diagnostic methods, and as well as the treatment strategies. And on that picture on the right, you can see, we'll get into this more, but that is a picture of osteomyelitis. Okay, so these infections are rarely fatal, but may be associated with long-term sequelae. In the 90s, one of the doctors had this comment: suppurative infections of the skeletal system still present challenges since these illnesses are often difficult to recognize and localize early in the course of illness, and many are difficult to manage medically and surgically. In spite of our best efforts, a substantial portion of those treated are left with disabling sequelae. So the goal of treatment is to minimize these risks. So musculoskeletal infections are really a spectrum of disease depending on the location of the infection. There can be abscesses, there can be an infection in the muscle, an infection in the joint, an infection in the bone, or a combination of all of these. And it can be a changing picture during the presentation. And the more severe the illness, the higher the lab values are. They may have to undergo additional surgical procedures. They can have a longer stay. They may need to be in the ICU. And also there's an increased risk of developing a DVT, so other complications. So who does this affect? So looking at osteomyelitis, it typically affects patients in their first decade of life. The mean age is about 6, so pretty young, and the prevalence is 1 in about 5,000 in kids that are less than 13 years old. It has about a 2.5 to 1 ratio from boys to girls. And on the right there, that is a picture of diffuse osteomyelitis as well as pyomyositis. We can think of stratifying patients into essentially 3 groups. So infants less than 1 year old and children over 1 year, as well as adults. Some of the risk factors we can think about, actually most kids don't have any. So this is commonly found in healthy children that have no other medical conditions or pre-existing diseases. But there can be an increased risk for developing osteomyelitis in patients that have an impaired host resistance. So particularly prematurity, so infants that are premature, sickle cell disease, any other immune deficiency, if kids have a malignancy or are undergoing any sort of chemotherapy, diabetes, chronic renal disease, a varicella infection, or juvenile rheumatic arthritis. So these are things that can impair the immune system and put kids more at risk for developing a diffuse infection. Okay, how do these spread? So the most common way that infections spread to the bone and develop osteomyelitis is through hematogenous seeding from a distant site. So they may have an infection elsewhere in the body, not from the bone, and it spreads to the bloodstream and then seeds the also be from direct inoculation, so some sort of trauma or a needle or an impalement from some other object going from outside in. Local invasion, so adjacent soft tissue or adjacent bone infection, so is spread. So something could be a pyomyositis and then invade the bone. So in that local area, the degree of the infection can change. And iatrogenic, so kids that are in the hospital more have other lines for other treatments. That can be a nidus for infection as well for things like if they need intraosseous line, that can be a direct inoculation into the bone that's iatrogenic. All right, why does this develop? So how does it go from the blood to the bone? There are nutrient vessels that form capillaries at the end of the bones, and they form loops. And the blood flow is slowed in these capillaries, and the oxygen tension also changes near the growth plate, and that can make an environment that's rich for the bacteria to grow. In infants less than 1 year old, they can develop what's called an involucrum, so something involutes. There's a temporary transient damage to the periosteum and disruption of the periosteal vessels, and something can be kind of pushed into the bone. And this is a schematic looking at kind of showing that area that's pushed in from the periosteum into the bone. And on the right top image, we can see a lytic lesion in the bone, but also a periosteal reaction around the shaft on that on that right femur there, tibia. The right tibia. And on the bottom image of the femur, you can see the left periosteal reaction with the development of that infection. In infants less than 1 year old, the infection that's in the bone can spread to the joint and cause permanent epiphyseal damage, so damage to the epiphysis, because the blood vessels can spread to the end of the bone and then spread into the joint. If this happens, that's a septic arthritis, and that can develop permanent articular damage within 8 hours of the infection spreading to the joint. And you can see on the bottom images a picture of the blood vessels that really extend from the metaphysis into the femoral head in this case, and on the right image, so those blood vessels go across the physis and into the epiphysis. So it's basically a direct connection, and it can spread from the blood throughout the bone and even into the joint. And there's no protection from the growth plate from this direct extension of it in patients that are less than 1 year. Some of the examples of the sequelae of osteomyelitis in kids, all of these imaging are showing abnormal bone growth and development. So there can be a limb length discrepancy, so the limbs grow at a different length. There can be joint destruction, so of the hip joint, the hip can sublux out of place. It can even fuse to the pelvis. There can be a lot of osteolysis and complete loss of bone of the femur. And there can be late sequelae of complete abnormality of the joint morphology. So this definitely has significant consequences that we really want to prevent. An even smaller group to think about is neonates, so 0 to 2 months. In these kids, they really have a very immature immune system. They're more at risk for foreign body inoculation from those multiple lines. Like for example, if they're in the NICU, they're more at risk for severe infections, including MRSA and Candida. They may be presenting this infection in terms of poor feeding, irritability. They may have temperature instability, and they could even have florid sepsis. They may not develop fever, and they're more likely to be at risk for infection in multiple sites because they have continuous spread from other sites. So there's not as much of a localized infection as there can be in older children or even adults, but they're more likely to have multiple sites. So, and again, in prematurity, 70% of the kids that are neonates that have osteomyelitis are premature, so that puts them at significant risk. All right, some questions I threw in here just to get you thinking. So osteomyelitis is a unique disorder in the neonate because of which of the following findings? All right, think about this. So epiphyseal extension from the metaphysis, multiple site involvement, and the presence of Staph aureus, or epiphyseal extension from the metaphysis, multiple site involvement, and the presence of group B strep, epiphyseal extension from the metaphysis, single site involvement, and the presence of group metaphyseal and single site with staph, metaphyseal and single site with group B strep. All right, so we talked about how the epiphysis extension from the metaphysis, so that blood flow that just extends toward the end of the bone, it can affect multiple sites, and group B strep in those infants because of the transmission from the mom. In kids older than 1 year, the growth plate starts to protect the epiphysis, so essentially a physical barrier of that blood flow all the way through to the epiphysis at the end of the bone. They can develop what's called an involucrum and a sequestrum. So a schematic on the right here is something involutes, the body starts to wall off this area of infection, and the sequestrum is that nidus that's in the middle there. And in the drawings on the bottom, you can see a caricature of the blood vessels that hit the physis and kind of come back. So that's preventing that blood flow all the way into the joint. And on the right, I have some more pictures of just that severe and bony involvement with osteomyelitis. Okay. Disease chronicity is rare. It's usually an acute event. It's not most of the time something that develops chronically. There's some sort of transient cortical damage, and again, you get that involucrum, so something's like pushed into the bone, and it actually can cause growth stimulation depending on where it is. So in the shaft of the bone can grow longer, but if it's affecting destruction of the epiphysis or a joint, that would more likely cause a growth arrest. All right, so again, it's a spectrum of disease and infection. So osteomyelitis and septic arthritis, or an infection inside of the joint, happens in about a third of the cases. And this extension can happen in those kids older than 1 year, but in joints that have a metaphyseal region that's intracapsular, so inside of the joint. And this unique anatomy happens in the proximal femur physis, so that is in the hip joint, the proximal humerus, or in the shoulder, the proximal radius, or in the elbow, and in the ankle at the distal lateral tibia. So this doesn't necessarily go through the end of the bone, but kind of sneaks out from the metaphysis into the joint. So in adults, in contrast, acute myelitis, osteomyelitis, is rare. Chronic infections are usually in the bone marrow. They may show a limited involucrum, so not quite as distinct on imaging there, and they are more likely to develop extraperiosteal abscesses, and they're more likely to have a chronic draining sinus, which is less likely to occur in children. Thinking about the microbiology, so different organisms affect kids based on their age, or they're more at risk for different ones based on their age. Still, across all age groups, Staph aureus is the most common. But looking at neonates, so less than 8 weeks, they're also at risk for that group B strep that we mentioned, but also gram-negative bacilli. Infants age 2 to 18 months are also at risk for Staph aureus, still far away the most common, but they're also at risk for strep pneumo, group A strep, E. coli, and Klebsiella. And in older kids, they're more at risk for developing salmonella and Neisseria gonorrhea. So what do we see on history? They may have pain that's constant and well localized, but pain may not be the main complaint. You really may have a kid that is showing up with a limp and a refusal to walk. They may refuse to move the extremity, and they may have referred pain. So an infection in the hip could be presenting as knee pain. And they may have a history of trauma or recurrent infection. So if a kid has a history of trauma, it actually doesn't make it less likely that it's an infection. It can actually make it more likely. The thought is that in a small trauma, there's a transient hematoma or some static fluid in that area, and that can be just enough of a nidus to incite an infection. And 30 to 50% have a recent or concurrent non-muscular infection. So we talked about if they have an infection elsewhere in the body, and most likely this is hematogenous spread from a distant site. Other things to think about on their medical history, including prematurity. If they have any other diagnoses such as asthma and they're on steroids, that would be another way for them to be immunocompromised and more at risk. And also thinking about any previous antibiotic treatment, making them more susceptible to resistant organisms. In physical exam, they may have a low-grade fever, and generally you're looking for, does this a child appear ill? Are they very irritable? Are they lethargic? Are they not eating? Are they tachycardic? Are they positioning a limb in a position of comfort. In this picture on the right, you can see the child's not really moving the right arm, looking for things that signs of inflammation such as erythema, swelling, and feeling of warmth. And the other thing to observe is if they have any spontaneous movement, if they're tolerating gentle range of motion, but also if they're guarding or have something called pseudoparalysis. They may not actually be paralyzed in that limb, but they're refusing to move it based on pain. So on this child on the right, things that could be causing this pseudoparalysis of the arm could be an infection, there could be a fracture. This child could have a brachial plexus palsy, but infection definitely should be in the differential diagnosis. All right, if a kid has fever and is tender over a bone, it's infection until proven otherwise. There can be many other things that mimic osteomyelitis. Trauma, there can be a periosteal reaction showing up like a halo around the bone when the bone is healing. Sickle cell disease, there could be a bone infarct, something called Capet's disease, which I have a picture on the right here. It's a genetic infantile cortical hyperostosis. So these images really show that periosteal reaction and development of bone, but that's actually not an example of osteomyelitis, although it looks very similar. Gaucher's disease, mucopolysaccharidosis, syphilis, and malignancy. There are certain neoplasms that can look like infection. There can be chondroblastoma, which is another lytic lesion, and Ewing's and osteosarcoma. There can certainly be that periosteal reaction and halo around the bone, things like that. So definitely on the differential, when you see a lesion on X-ray, to also be thinking about what other neoplasms this could be. So what do we see on an X-ray with osteomyelitis? Visible on the X-rays is osteolysis, so a lytic lesion or a darkening, so less white on that X-ray, when there's about 30% loss of bone density. So it takes a significant amount of bony changes to show up on an X-ray. And in the time frame of this, it usually takes about 7 to 10 days. The earliest finding, however, is soft tissue swelling, and that can show up in about 48 hours. And another thing, that periosteal reaction, or that halo that we can see in that right image on that right tibia, shows up in about 5 to 7 days. All right, another question. A 4-year-old boy has a fever and has been unable to ambulate for the past 48 hours. Examination reveals tenderness to palpation over the distal aspect of the right femur and no appreciable joint effusion. Laboratory studies show a white blood cell count of 13,000, so elevated, and an erythrocyte sedimentation rate, or ESR, of 54, also elevated. Which of the following radiographic findings is most likely to be present? A well-circumscribed lytic lesion, a periosteal elevation, sequestrum, deep soft tissue swelling, or cortical erosion. Deep soft tissue swelling. So in the first 48 hours, there's not really any bony changes that you can see on the X-ray, just that swelling. What other imaging do we use? So ultrasound can be particularly helpful in hip effusion and to evaluate for any subperiosteal abscess. It wouldn't really show an intraosseous abscess, but subperiosteal we can see. And a negative study should not delay aspiration if you have a high enough clinical suspicion. So it can certainly be helpful, but if it's negative, it doesn't rule anything out. An MRI is particularly helpful in evaluating for infections in the pelvis and spine. It can differentiate between a deep soft tissue infection versus osteomyelitis. It can also help guide a surgical approach for drainage to decide on what the safest path would be and the most effective path. The sensitivity is about the same as a bone scan, but the specificity is higher than a bone scan. All right, and a CT scan can show gas related to the development of the infection, and also can characterize that sequestrum, or that walled-off infection in the bone. And on the right here, I have some MRI images showing that diffuse infection in the bone, but also the development around the bone. We also have some bone scans. They can be helpful when the site is unclear or if it seems that multiple sites are involved, and it can also help differentiate between an infection in the bone or just in the soft tissues. It's very sensitive, but it's not very specific, indium bone scan for tagged leukocytes is more expensive, and it increases the radiation and time, but the accuracy can be increased following a negative bone scan. And an indium bone scan is very accurate, and it's more used in the setting of looking at for chronic osteomyelitis. Okay, you're asked to consult. So put yourself in my position now. You're asked to consult on a 4-day-old neonate admitted because of failure to thrive. She has swelling of her left shoulder. Examination reveals limited motion of her hips and left shoulder. Radiographs of the shoulder and pelvis are negative. Laboratory studies show a white blood cell count of 24,000, an ESR of 50, and a CRP is 16. What is the next most appropriate step in management? Should we ultrasound the hip and shoulder, get a bone scan, get an MRI of just the shoulder, put her in a Pavlik harness, or jump to an excision and drainage? Ultrasound. So that can be very helpful for looking for that effusion as the next step. And it also doesn't involve any radiation, so very helpful, especially in the setting of a neonate. Okay, so what lab tests are relevant? So you want to get a CRP, an ESR, a CBC with differential, and get blood cultures. But these are positive in about 30 to 50% of cases. And you can also look for another source of infection by getting a throat culture and a rapid strep test. So kids could have a respiratory infection that spreads to the bone. And other things that we've learned that can also predict the presence of MRSA are looking at the levels of all of these too. So not only can this help diagnose osteomyelitis, it can also help predict what organism is found. And the other thing that goes along with MRSA infections in kids with osteomyelitis and a little bit older kids is the development of DVT. They're more at risk for developing a DVT if they have a MRSA infection. Okay, so why CRP? It's almost always elevated, and in about 98% of acute hematogenous osteomyelitis, there's an elevated CRP. So it begins to rise in 6 to 8 hours after the start of the infection. It usually peaks within 24 to 48 hours. And we can use this to more closely follow the clinical course, the effectiveness of therapy, and recovery. So this is the lab value to follow during their course. And it's more sensitive than ESR or the white blood cell count. In children with osteomyelitis, CRP levels are influenced by needle aspiration, splint immobilization, levels of protein S and C, resolution of the infection, or location of the infection. Resolution of the infection. So this is what to follow while they're being treated with antibiotics. ESR, it may not rise during the initial 24 hours, so it could initially be low if you're catching the kid early in the course. It's a slower rise, and it peaks about 3 to 5 days. It remains elevated for about 3 weeks, so this is not going to drop off as quickly as the CRP. And it's less reliable in neonates and in patients with sickle cell disease, but it is elevated in about 90% of cases with osteomyelitis. A 6-year-old boy with acute hematogenous osteomyelitis of the distal femur is being treated with IV antibiotics. The most expeditious method to determine the early success or failure of treatment is serial evaluation of which of the following studies. So CBC count with differential, an MRI, CT scan, radiographs, or CRP. CRP. All right, our treatment. So the goals are really the best effective treatment, early recognition, and then to define the diagnosis of the pathogen. We can also use a bone aspiration to guide to the treatment, but this is positive or results in an organism in about 50 to 85% of cases. Another true or false. Aspiration of bones and joints alter the results of later bone scan or MRI. False. So really, if there's a clinical indication to aspirate, then go ahead because it's not going to affect the later studies, and so those can also be done for further evaluation. Okay. Osteomyelitis is a medical condition, and the treatment is appropriate antibiotics. That is the first line. Sometimes we have to add surgery when it's indicated, and very important to get the infectious disease team involved early. So from my surgical perspective, the answer is not always coming from me, and it's always a team effort involving the infectious disease team. All right, we treat in light of local epidemiological patterns, so also the infectious disease teams can help guide this, and endemic organisms and antibiotic resistance vary by geography. So some examples of empiric antibiotics to start before we know the organism are here. So clindamycin, vancomycin, ampicillin, based on age. But these can also vary, again, depending on geography. So when do we do surgery? We do it when the antibiotic penetration into the infected site is impaired. So that happens when the body starts to wall off this infection with that sequestrum or an abscess. The antibiotics that are spreading through the blood are not necessarily going to be appropriately treating this. If we do a bone aspiration and there's gross pus there, then that would be an indication to surgically debride that area. And also if there's a subperiosteal abscess. So not just an abscess in the bone, but also under the periosteum. If there's an extension to an adjacent joint, so if we're dealing with a septic arthritis, that is a surgical indication. And also if the patient's not responding to that medical treatment in 36 to 48 hours, but they would still stay on those antibiotics or alter them based on what we find, but sometimes in that case it's appropriate to go ahead and debride the bone. Right. Chronic osteomyelitis. So in thinking about the time frame of these infections, and not just the location of them, we can define osteomyelitis in terms of subacute or symptoms that are ongoing for more than about 2 weeks, and this can be a development of what's called a Brodie's abscess, or really seeing that involucrum and sequestrum at the beginnings of it. So on the right here, we can see that walled off area of infection and some edema around it. So more chronically, it gets even more walled off, and there may not be those acute symptoms to go along with it. This may develop after an open fracture or inadequate treatment for acute hematogenous osteomyelitis. The symptoms are more likely to be mild, and there may be intermittent acute exacerbations, but rarely is this illness systemic. The labs could be normal, and it's usually Staph aureus, which is far and away the most common organism for all of these, and the treatment is a longer-term antibiotics, and often with surgical debridement, again because that area is not going to be particularly well penetrated by the antibiotics. All right. A 12-year-old boy has a mild ankle pain and a limp for the past 2 months. Laboratory studies show a white blood cell count of 7,000 and an ESR of 40. Radiographs of a T1 weighted MRI scan are shown, and management should consist of, all right, let's go show you some pictures of the tibia. Okay, antibiotics, non-steroidal anti-inflammatory drugs, percutaneous radiofrequency coagulation, a clamshell orthosis, or observation. Antibiotics. In this case, we would probably add surgery as well, but again, the first line treatment is antibiotics. Getting into more not quite so simple things, chronic recurrent multifocal osteomyelitis is actually not the same thing as acute osteomyelitis. So it's recurrent episodes of bone inflammation, pain, low-grade fevers. There can be multiple bones affected, and it can be periodic and with exacerbations and remissions. The cultures can be negative, and the natural history of this is actually that it burns out with time, and antibiotics don't affect the disease course, and you really observe and are very supportive in the treatment. But because this can cause permanent changes in the bone, it's important to follow them until maturity, at least from my surgical perspective, because deformities can develop, and sometimes those secondary deformities have to be addressed. Septic arthritis is an orthopedic emergency. This is something we treat even in the middle of the night, and in fact do want to. This is an inflammatory effusion, and on aspiration the fluid comes back with over 90% of polymorphonuclear cells. These cells release proteolytic enzymes, And this is what causes the irreversible cartilage degradation in about 8 hours. This can destroy the head and epiphysis, so in the hip joint, the femoral head. It can cause subluxation or dislocation. It can cause avascular necrosis, growth disturbances, chondrolysis, so devastating consequences from this. An adopted 2-year-old girl with a limp is seen for an orthopedic evaluation. The child has no other clinical deformity or radiographic abnormality other than the right hip deformity noted in this picture. What is the most likely cause of this deformity? Idiopathic chondrolysis, developmental dysplasia of the hip, a slipped capital femoral epiphysis, the sequelae of untreated septic arthritis of the hip, or Pavlik harness disease. So you can see on that right hip that the morphology of the proximal femur is very abnormal. The epiphysis is very small. The hip is dislocated and migrated proximally. This can be what happens from the sequelae of untreated septic arthritis of the hip. So devastating for this hip. Septic arthritis, it's usually from a hematogenous seeding of the synovium. It can be from the contiguous spread of osteomyelitis. So in those neonates, it can just simply spread from the osteomyelitis that's there. And in older children, those 4 joints that have the intracapsular metaphysis. The peak incidence is children less than 3 years old. It's a little bit more prevalent in boys. And unfortunately, it does have a likelihood of having a delay in presentation of 3 to 4 days. The most common organism is MSK, but there can be at risk for other infections, especially if it's hospital acquired. Okay, where does this happen? Most often it happens in the hip and knee. This is from one study looking at 2 different hospitals, and both the hip and knee were most commonly affected, but it can spread to the ankle, shoulder, elbow, wrist, and it can be in multiple joints, and that's more likely to be in those neonates. Normal capsular anatomy of the older child provides increased opportunity for acute hematogenous osteomyelitis of the metaphysis to extend to an associated septic arthritis at the, all right, so which joints were these? So distal lateral tibia and fibula and distal femur, the distal first metacarpal and proximal tibia, proximal radius and proximal tibia, proximal femur and proximal radius, proximal humerus, and distal first metacarpal. Proximal femur and proximal radius, so in the hip and then the elbow. How do these kids present? So most of them have pain and decreased joint range of motion. They may be irritable. They can have a history of recent illness. They can have a fever. They may have a history of trauma, and a smaller portion have multiple joints involved. Thinking about more broadly about the differential diagnosis when we see a limping child. Also on the differential high up there is transient synovitis, which is not a true septic arthritis, but it's more a reaction in the hip. There can be juvenile JRA, rheumatic fever, post-streptococcal reactive arthritis, a hemophilia, Lyme disease, gonococcal arthritis, scipia, the slipped capitofemoral epiphysis, leg Perthes disease, which is a hard-to-treat idiopathic avascular necrosis of the hip, or a traumatic effusion, so trauma. Very important to think about what is the clinical prediction of septic arthritis versus transient synovitis, and Dr. Coker came up with a Coker criteria. So each of these characteristics of the patient can help make it more likely that they have a septic arthritis versus a transient synovitis. If they have a fever over 101, if they're non-weight bearing, they won't bear weight on a leg. So these are specific for of the hip. These were criteria were developed. ESR over 40, and a serum white blood cell count over 12,000. So a 99% clinical prediction if they have all 4 of these things. And then in a subsequent study, they adding CRP increased the ability of these to predict septic arthritis. So if we get an ESR, CRP, we get the CBC to look at the white blood cell count, look at their vitals to look if they have a fever, and really examine the child to see if they're non-weight bearing. These can all increase our clinical prediction of diagnosing that septic arthritis. No test is pathognomonic for septic arthritis, and these are really rules of prediction. So there is a lot to be said for the clinical judgment and assessing whether or not this kid might have septic arthritis. A 2-year-old boy is not moving his left hip. The patient was delivered 6 weeks prematurely by cesarean section. He has no fever. Examination reveals some mild swelling about the left proximal thigh, and passive movement of the hip appears to elicit discomfort. A radiograph of the pelvis shows widening of the femur to teardrop distance on the left side. What is the next most appropriate step in management? Observation, a Pavlik harness, modified Bryant traction, an MRI, or aspiration of the hip. Aspiration of the hip. So this patient seems to be localizing that swelling to that thigh, and passive movement of the hip is irritable. He was just born, so very at risk for all of these infections in the acute setting. And if it's really localizing to the hip, the next step is aspiration. Right. So we aspirate, and then we start empiric antibiotics. So all of these other predictors can help increase the diagnosis of septic arthritis, but once we're thinking about that, then the next step is to aspirate. We can look at the synovial fluid and inspect it for color and clarity, looking for the strain test, how thick it is. Looking at the cell count are probably the most important ones. The white blood cell count over 50,000 and more than 90% of PMNs. We can send it for cultures with sensitivities, get the gram stain, and also look at the levels of glucose and protein. These are some of the most likely organisms that we find in septic arthritis. So still Staph aureus, high up on there. Also group B strep, strep pneumo, which is less likely, a little bit farther down on there, but these are the most common ones. Okay, so poor outcomes are most associated with the delay in diagnosis. So that's why the part of the treatment is early recognition, and we have to have a particularly low threshold for aspiration and proceed with prompt surgical drainage. Again, this is the orthopedic emergency that we want to know about in the middle of the night, in the middle of the day, because it can cause destruction of that joint within 8 hours. Antibiotic therapy is very important to involve our infectious disease colleagues, and then we can adjust the antibiotics to the cultures that we find, and eventually transition to an oral route after treatment with IV antibiotics for a period of time. Okay, we'll see if this works. So I thought this would be fun to watch a video on an example of how to drain a hip from one of our esteemed colleagues. Let's see if this works. Okay, not sure this works, but essentially making a bikini incision, getting down to the joint capsule, making an incision in that joint capsule, taking out a piece of that, and then you can place a drain for a couple of days afterwards to gravity. All right, a 5-year-old boy is seen in the emergency room with a 3-day history of limping and painful range of motion of the left hip. He has no history of trauma. Observation of his gait demonstrates the ability to bear weight, although he has a notable limp. Radiographs are seen in figures A and B. He is afebrile, and his labs include an ESR of 20, normal is less than 22, CRP of 18, normal is less than 20, and a white blood cell count of 9, so also in the reference range. Which of the following most likely preceded the onset of his symptoms? So a hematogenous bacterial inoculation of the joint, infectious respiratory illness, hypothyroidism, exposure to secondhand smoke, or a limb length discrepancy. Infectious respiratory illness. So this is an example of that transient synovitis. So the labs are not elevated, he's not overall very ill, and he has ability to bear weight, but he does have a limp, so not a complete refusal to bear weight. All right, and then there. Change of focus. So a 7-year-old boy has had low back pain for the past 3 weeks. Radiographs reveal apparent disc space narrowing at L4 to 5. The patient is afebrile. Laboratory studies show a white blood cell count of 9,000 and a CRP of 10. A lumbar MRI scan confirms the loss of disc height at L4-5 and reveals a small perivertebral abscess at that level. To achieve the most rapid improvement and to lessen the chances of recurrence, management should consist of oral antibiotics, IV antibiotics, surgical drainage of the perivertebral abscess and IV antibiotics, bed rest, or cast immobilization. IV antibiotics. So this is an example of discitis. So it's an infection in the disc space. It usually comes from a hematogenous seeding of the end plate, so it's spread to the disc, and it can also spread out to the adjacent metaphysis. So in children less than 8, there's more, again, of that contiguous blood vessels spanning the vertebral body and the disc. Similar idea of that less than 1-year-old in the child, and thinking about in the long bones, and that's why they're more at risk for this development of that discitis, spread from the osteomyelitis of the spine. So they can present with a refusal to walk. It can present as back pain, although only in about 27%. They may have an inability to flex the lower back, or a loss of lumbar lordosis, and it's more likely to develop in the lumbar more than the thoracic or cervical spine. And on the right here is basically an illustration of that loss of lumbar lordosis on clinical exam as well as x-ray, and that's usually the first radiographic finding. They can present with hip or abdominal pain, and they can also have pain at night. The ESR typically is mildly elevated. The blood cultures can be positive acutely. An MRI is very helpful and is the most sensitive study for diagnosing this. X-ray findings may show up at about 2 to 4 weeks. Aspiration is positive on about 60% of the cases, but it's usually unnecessary to do that aspiration, and typically we do that only if there's a worsening clinical picture despite antibiotics. So antibiotics are still the first-line treatment, and typically for about 6 weeks. And then sometimes we can include bed rest, a cast, or a brace as needed, depending on how much it's affecting that spine. Just to skip to those x-rays on the right, what you can see is disc space narrowing, so a collapse of those vertebrae closer together on the AP and that lateral x-ray. We're not yet seeing destruction of that end plate, and we're not seeing a complete obliteration of that disc space, which can develop later. And also, if they're not responding in about 3 to 5 days, you want to think about what else could be infected, and they could have developed an epidural abscess, and that would definitely need debridement. All right, other fun things. Lyme disease, so it's caused by a spirochete and carried by a tick. There's 3 stages really. So the rash, you can have that erythema migrans. They can also develop carditis, neuritis, or that rash. And they can also develop arthritis, but it can be acute, it can be polyarticular or migratory. So that can also look like a septic joint, but they're not quite as ill as if it were true like staph infection in the joint. And it's diagnosed with an ELISA or Western blot test, so we can send titers, but we can also aspirate the fluid in the knee. It's usually a knee. It can be in any joint though. And the treatment is typically amoxicillin or doxycycline. A 6-year-old boy develops tenderness at the right heel and avoids putting weight on the right extremity after stepping on a nail 2 weeks ago while wearing tennis shoes. His mother notes that he had a fever of 39 degrees Celsius. Calcaneal osteomyelitis caused by a puncture wound has an increased rate of which of the following compared to hematogenous osteomyelitis? So, is it more likely to have group A strep, coliform, Haemophilus, Pseudomonas, or group B strep? This one is that Pseudomonas. So foot puncture wounds, think also Pseudomonas. In the acute stage, we typically superficially debride the wound, make sure they have tetanus prophylaxis, and most of them don't actually need antibiotics, but if it is a later presentation of a foot puncture wound, then we treat against staph, which is the most common in all of these, and then think about including treatment for Pseudomonas. And then if it's later looking for an infection elsewhere in the bone or in the joints of the foot. Staph is most common, Pseudomonas particularly in injuries that happen in dirty water like lakes, and it really is very destructive to cartilage. We can help get an MRI for localization of where this infection is, and that could also help guide surgical debridement. On the right here, I just have a picture of cellulitis, but as a reminder, there can be a spectrum of infection when we're talking about this. All right, just kind of wrapping up with a few things. So there are particular microbiology organisms that are more likely in certain settings, so based on age group and location of the infection. And remember that neonates are particularly vulnerable, and they can get that group B strep. There is a disappearance of causative organisms after introduction of community immunization programs, so that H flu, synovial fluid gram stain can be negative. So we have an improved ability to isolate certain organisms and isolating in a blood culture bottle or holding that incubation in the lab for more than a week, and PCR can be helpful. So sometimes when we don't get a positive culture, holding these cultures for a longer amount of time can be helpful to truly isolate this. Most common organisms of musculoskeletal infections in children, so some of them on the right, you really want to be thinking about the geography that's related, so knowing what's most endemic to an area, and then based on the age of the child. So again, in kids that are a little bit older, and especially in cases with MRSA, they're more likely to also develop a DVT. Think about osteochondritis, so an infection in the joint or affecting the cartilage after puncture wounds of the foot. In sickle cell, they should have broader coverage. So in those patients, they're still more likely to have a Staph aureus infection, but they're more at risk for also salmonella. And then another, just to throw in there, another atypical cause can be with cat scratch disease. So really think broadly when you're treating kids. All right. In summary, so unexplained bone pain and fever is osteomyelitis until proven otherwise. Early diagnosis is key. Good clinical judgment is indispensable and very helpful in surgical decision making. So if surgery is not the first line treatment, antibiotics is recognition and antibiotics. We really do get a lot of help from our pediatric infectious disease colleagues. They need to be involved early, and they can help really guide the treatment. And remember that it's a changing picture. It's a balance between those antibiotics, the host resistance, so any impaired function of the host, and the virulence of the organism. So depending on what organism it is, whether it's MSK, MRSA, other things. Surgery is indicated if there's gross access, basically if we can access the area safely, and if there's lack of clinical or laboratory improvement, so thinking about the ESR, and after treatment with appropriate empiric antibiotics, and later we can focus the treatments based on the cultures. Long-term follow-up especially may be needed with an orthopedic surgeon to ensure that the severe infection does not lead to deformity, limb-length discrepancy, or functional limitation. And thank you. And we'll see if I can go to any questions, but feel free to call our office, visit our website. You can email me with any questions later. I'm happy to take anything now.
Thank you, Dr. Stelma.
Thank you.
As a reminder, the text chat is located on the right-hand side of your screen. To submit a question, please type your question in the text box at the bottom. Then when you're finished, hit the send button. Please note that due to our time constraints, our speaker may not respond to all the questions, but she is happy to take some now. And if you stop sharing, Dr. Stelma, you should be able to see our questions, or I can read them off for you, whichever is easiest.
Sure. Maybe you can help me by reading them off.
Sure. First question in our queue is, in a primary care office with early presentation of suspected osteomyelitis, what is the best course of action? Call ortho to facilitate urgent care appointment, or to send to the ER?
That's a great thing to ask. So I think you can always reach out to an orthopedic office, but if the kid is seemingly acutely ill, if they're febrile and they look overall, I guess, toxic, they would need to go to the emergency room. If it's more of a chronic picture, then if you can send off labs for further evaluation, I think most pediatric offices can get that somewhat quickly. That can be very helpful. If you have any access to x-rays, that can also be helpful. But I would say if the child is acutely ill, the emergency room is the place to go. And certainly we do have some urgent care hours in our office, which can, if that's easy to reach within a day or two, that can also be very appropriate.
Thank you. The second question is, question needs to treat for DVT in neonates or children?
Yeah, I don't think we need to prophylactically treat for DVTs in the neonates. It's usually in kids that are a little bit older, in essentially teenagers and a little bit older. They're more at risk of the DVT with a MRSA infection. I wouldn't prophylactically treat. I wouldn't give them prophylactic treatment for a DVT.
Next question. What about the fractures as a late complication OM?
Yes, if there's a lot of bony destruction, they can be more at risk for that. Usually we do protect their weight bearing as they're healing, and we're following the resolution of the infection. I think once the bone is healed and they've gone past the acute stage, they're not necessarily at risk for a fracture. And most of the acute episodes of this don't develop into a chronic state. So I think they're not necessarily a risk unless it is an ongoing infection. So in the acute stage, we do typically restrict their weight bearing if it is affecting more of the diameter of the bone.
Right. That was the last question that we had so far. A reminder to our attendees, there is still a few minutes left to submit your questions, and our speaker is still ready.
I think the other thing to remember with these is it really is a spectrum of disease, and the long-term sequelae are very specific to each patient, and that's why we typically follow them for a long time afterwards as well, and to address things like deformity or the risk of fracture later if they haven't completely resolved the infection, the bone hasn't gone back to normal completely. A lot of these kids, remember, are totally healthy before, so particularly focusing on that long-term sequela can be very important to limiting the sequela.
Okay, it seems we are out of time. On behalf of Atlantic Health System Morristown Pediatric Orthopedics, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey that will request your feedback. Please do take a moment to complete this survey in order to receive credit for providing feedback and attending our webinar. This concludes today's program. Thank you and have a great day.